Well, good evening, ladies and gentlemen, and thank you for staying. I'm glad that the A-team have stayed to the bitter end. I've got 15 minutes to tell you all about marginal gains in IVF. This was a term that I don't own, but was devised by David Brailsford, that I'll mention a little bit later on in the talk. I've got 15 minutes. I'm going to give you a whistle-stop tour. My background in IVF is that I've been the lead for Liverpool IVF services for the past 25 years, and I'm now Professor of Reproductive Medicine at ESHRE University, which is a new university which received its charter in 2006. Liverpool, for those of you who don't know, very similar to Barcelona, on the coast, sun-kissed beaches, Mediterranean-style weather. The two things that are a little bit different to Liverpool is that we've got two cathedrals, and we've got these four. Now, if you fall asleep or find this boring, I'm going to offer you a quiz question. If you get it right, then you get a prize, courtesy of CooperSurgical. Very recently, the New Musical Express the editors voted on what they thought was the greatest pop song ever written in terms of music and lyrics. And they voted, and this group won for a song they wrote in the 1960s. And I will ask you what you think that song was. They voted the greatest pop song ever written. Okay? This was where I started my IVF in Bourne Hall on March the 1st, 1988. Patrick Steptoe died a week later. I hope it wasn't a coincidence, but this was my mentor. He supervised my MD thesis. I moved to Liverpool in 1989. This was my first IVF team. Believe it or not, there I am. Christine Malone is still the matron in charge. Lorraine is still an embryologist. Claire went off and had a family. And I don't know whether any of you know, are any of you gynecologists from Britain? This is David Richmond, who went on to become the president of the Royal College from 2013 to 2016. That was my first staff of 5. There are now staff of 125. This was my MD thesis, and a lot of the things I'm going to talk about in the next 11 minutes were contained in this aspects of in vitro fertilization, in which I tried to look at the ways in which we could improve outcomes in IVF at that particular time. These were 2 or 3 of the papers I wrote at the time. The main tenet of my thesis was to look at ways in which GnRH analogues could be used to downregulate effectively IVF. Is that all right? Is that working okay? So this is David Brailsford. David Brailsford, for those of you who don't know, is the head of Cycling UK. 12 years ago, when he took over, cycling was a recreational sport. Now we are the world leaders, the Olympic leaders in terms of winning medals at the Olympic Games in cycling. And he had a particular thesis in that if he could improve outcomes of cyclists by 1%, improving wheel technology by 1%, or the quality of the pedals by 1%, or lung function in the cyclist by 1%, all these would accumulate and improve your outcomes significantly to become a world beater. And that's effectively what he did. So he looked at all aspects of cycling, and I want to look in the next 9 minutes of all aspects of IVF. And we still do 4 basic things: ovarian stimulation, oocyte retrieval, embryology, and embryo transfer. So if we look at ovarian stimulation, I think now we can safely put the question to bed as what's best, antagonist or agonist? Antagonists are just as good, if not better, than agonists. Now we know how to use them. We get successful outcomes. Patients like them. They're much easier to use. They're much easier to control. We get a reduction in OHSS. And there is no difference in live birth rates in patients that are stimulated or downregulated with GnRH antagonists or agonists. Ovarian stimulation, I don't know whether you've been to any lectures on different gonadotropins, but I'm sure that you'll hear the same sort of lectures looking at randomized controlled trials, comparing recombinants and urinaries that we were going to in the late 1980s. There's no difference. Recombinants urinaries. The outcomes are very, very similar. What we can say from the randomized data and the meta-analyses is that certainly urinaries are no worse than recombinants. They may be better, but they're certainly no worse when you want to stimulate your patients. AMH, I'm still not quite sure the real role of AMH, but one of the roles that I can be sure of, it helps predict gonadotrophin dosage for outcomes of IVF. So this is the algorithm that we use based on a pre-stimulation AMH. If we've got an AMH of over 40, we use low-dose antagonist, agonist, trigger, and freeze all. If we've got an AMH between 20 and 40, low-dose FSH, antagonist, and HCG trigger. Normal response, antagonist, HCG trigger. Low response, probably a flare or antagonist with a higher dose of FSH. That helps us. Go on to oocyte retrieval needles. If you look at the diameters of needles, 16 gauge and 18 gauge, I'm very conscious of pain and disruption to the ovary when we use 16 gauge needles. Now, we need a diameter, an internal diameter to get an egg through of about 0.75 millimeters. If you look at a 16 gauge, if you look at an 18 gauge needle, the overall area is 1.19 millimeters. If you look at a 16 gauge, it's nearly twice the size. You're thrusting that through an ovary with all its concomitant pain, disruption, hemorrhage, when you can get just the same effect with the same internal diameter as a 18 gauge needle. So what you want is the widest internal diameter with the narrowest external diameter. I've just started working for IVI UK. We're using these huge double channel blunderbuss plumber's pipes that we have to walk into thrust it through, and I'm not too sure. I don't know why we do it. It certainly causes a lot more pain, and if it was my ovary, I prefer to use a nice whippy single channel myself. Rocket suction pumps still, we still have a different view on the negative pressure that we have to aspirate. We shouldn't be using greater than 100 millimeters of mercury in terms of negative pressure. If we have to put 150, 200 to aspirate your follicular fluid, you're probably damaging your ovaries. So less than 100 millimeters of mercury. The NICE guidelines are here to help us. For those of you not from the UK, the NICE guidelines are the National Institute of Clinical Excellence. They get every 4 years, they get a bunch of the great and the good to sit around a table in London over lunch to look at all the evidence base in a particular specialty. IVF was reviewed in 2017, and here it is, the evidence. Women have developed at least 3 follicles before oocyte retrievals, should not be offered follicular flushing because this procedure does not increase the number of oocytes retrieved or pregnancy rates, and it increases the duration of oocyte retrieval and associated pain. There it is, the evidence base. In 2010 in the UK we had a minimum birth, multiple birth minimization strategy, so we're looking to adopt a reduction in twinning so that most of our embryo transfers are single embryo transfers. That puts a lot more emphasis on picking the right embryo. And this is the standard embryological technique. We do the egg collection. The following day we get the embryo out. We look at it on day 1. We put it back. On day 2 we don't bother. On day 3 we get the embryo back. We put it back into the incubator. We get it out again. We check it again on day 5. And then we decide whether the blastocyst is good enough to replace. Well, I don't know about you, ladies and gentlemen, but certainly as a clinician, time-lapse technology has improved dramatically the clinical aspects of IVF. I'm not sure whether it's the time-lapse per se that has improved outcomes, but certainly it's focused the mind as to the techniques we use to develop and grow the embryos. This was an early embryo viability assessment that we now no longer use, but that was the sort of one of the forerunners to time-lapse that we now have in our laboratories. This was the world's first EVA baby, born to a 42-year-old lady, Ruth Carter. This is quiz question number 2. These were her 5 embryos. Which was the one that turned into the baby? Any guesses for the second Cooper Prize? A1. So, time-lapse technology. Patients understand time-lapse. Whether embryologists think it's great or not, there's no doubt that patients like it. It doesn't do you any harm. It may be the closed incubation system that improves outcomes. It may not be anything to do with the time-lapse, but it certainly doesn't harm. It brings embryology into the clinic. When you can explain to the patient why she didn't get pregnant, one of the most difficult conversations you have with patients is those who didn't get pregnant. Why didn't I get pregnant? Well, 10 years ago, we clinicians, this is a secret, embryological colleagues, we'd say, well, it's probably a problem in the embryologist, and we don't know, but it might have been the laboratory. It's certainly not us, but it's, blame somebody else. Nowadays, we can show them, this is actually what a normal embryo grows like. This is what yours grew like. And they'll look at you and they'll say, oh yeah, that's not very good, is it? And say, no, they make the diagnosis themselves. It demystifies the laboratory. It demystifies the embryology for us clinicians as well. And we use 100% time-lapse technology. IVF, fresh embryo transfers versus frozen embryo transfers. Well, for me, vitrification has been one of the great breakthroughs in the last 20 years. It really has enhanced outcomes from frozen embryo transfer. So we're no longer afraid of freezing embryos, because we know that in the right environment, when we thaw them replacement, the outcomes are every bit as good, and in some cases better than fresh embryo transfers. Embryo survival rates from vitrified embryos are brilliant. We no longer worry about the standard freezing technique of 75% thaw rates. We now get, well, over 95. So this is our recipe at IVI UK. We blastocyst culture, we use time-lapse, we use a single embryo transfer in over 80% of our patients, and we vitrify the remaining blastocysts that are good enough quality to vitrify. When do we put them back? I think this is a very useful new initiative. I'm not sure whether it's reached evidence base yet, but we measure now the pre-embryo transfer serum progesterone levels to see whether the endometrium's in sync with the embryo, and if the progesterone on the day of HCG is greater than 1.5 nanograms per mil, then we vitrify the embryo. So the quality of the embryo is transferred, and the progesterone levels, the serum progesterone levels, are the most important predictors of live birth after a fresh embryo transfer. This was a paper from 2014. Does a frozen embryo transfer ameliorate the effect of elevated progesterone seen in a fresh transfer cycle? Paper from 2015. Yes, it does. So if you've got raised progesterone levels, vitrify the embryo, put it back in a frozen thawed cycle. And finally, embryo transfer. The procedure of the embryo transfer is of vital importance for successful outcome after IVF treatment. Therefore, a careful atraumatic embryo transfer in skilled and experienced hands can maximise the chance of pregnancy. That's from a textbook 1980. The situation hasn't changed, yet we still see variations of embryo transfer technique. It is one of the most difficult skills to learn. We can teach anybody, ladies and gentlemen, to collect eggs or stimulate ovaries based on standard protocols, but you try teaching clinicians or nurses, as we do, embryo transfer, and it's much more difficult, particularly when you're trying to teach clinicians, because they don't do what they're told, they don't follow protocols, they get up a skill set and then they leave. So what we need to do is we train the people who stay, who transfer, who are not going to leave. who follow protocols and who follow a standard procedure, and they are the nurses. So there's been some debate for many years over whether we should use ultrasound-guided transfer or a more no-touch technique or a blind technique. You wouldn't eat your dinner with your eyes closed, so you wouldn't do a laparoscopy with your eyes closed, so why do we do an embryo transfer with our eyes closed? In fact, if you look back in the literature in 2006, I published a randomized prospective controlled trial on looking at ultrasound-guided embryo transfer and non-ultrasound, and there was no difference. I've changed my mind. There is a difference. We just weren't doing the ultrasound very effectively. There are now catheters that enable us to see very, very clearly where we're putting our embryos. So we see an exact position where the flash occurs, just at the top of the fundus, and we can then photograph it. The patient likes to see it. There's your embryo. We're putting the embryo in now. There's the flash. There it is. It's inside your uterus. This is a picture of an embryo transfer catheter. These are the sort of standard pictures we would see. And this is an algorithm that we borrowed from our California colleagues. As a rule of thumb, we like to put the embryos in the midpoint between the crossing of the two fallopian tubes. So it's at the mid. That's the MIP, the point of maximal implantation, in the top third of the uterus, about the uterine cavity, about a centimetre from the fundus. 4D ultrasound guided transvaginal approach, bit messy, bit difficult to do, takes a long time, not sure whether it's of any benefit, but it certainly makes very, very pretty pictures. So, what do I say about ultrasound-guided embryo transfer? It facilitates the entrance of soft catheters into the uterine cavity. We don't need to batter our way in with rigid catheters. It confirms that the catheter is located past the inner os. And I'm sure if you're honest, ladies and gentlemen, particularly the clinicians, that in your early days when you were learning, have you not put an embryo transfer catheter in when you're sure you're in the cavity, only to move it backwards and forwards and to see that the tip is actually curling round and coming back on you? Anybody seen that? You're telling fibs if you haven't. A full bladder helps to align the uterus, giving a clear ultrasound image. It visualizes the exact location for depositing the embryos. Patients love it when you show them where their embryos are going. So the key points that we have for embryo transfers: we use an ultrasound, we use soft catheters, we deposit embryos in the mid-cavity. There's no such thing as a difficult transfer. They never happen. In the same way, there's no such thing as a difficult forceps. A difficult forceps delivery is an easy cesarean section. I don't want to be the victim of a difficult forceps delivery. Neither do my children or my grandchildren. Similarly, when I want to put embryos back, it needs to be easy. So we practice. We practice with a trial embryo transfer in the ovulation period of the cycle. If it's difficult, we use a stylet. If we can get in with the stylet, we then document it so that the person doing the embryo transfer knows the way to get in. And if it's even more difficult with a stylet, we do a cervical dilatation. No need for bed rest. When I was at Bourne Hall in 1988, we used to have patients recovering for 48 hours after embryo transfers. We used to go round for ward rounds. I remember the consultant in charge would come round and say, now this lady is 48 hours post embryo transfer, how are you feeling? And she'd look at you and go, bored. And why we were keeping them there, and sometimes we used to keep them in the head down position. So not only were they bored, but they were bored with a headache. And why we did that, I don't know, because the embryo it's like a bubble in a bottle of pop. It will float upwards, so if you put the patient head down, it just floats back up that way. So you want to stand up. No need for bed rest, no medications. There's no evidence that progesterone, anti-inflammatories or anything else is of any benefit to improving implantation at the moment. And finally, and most importantly, do loads. Do loads. Because the patient, the girls that do our embryo transfers we only allow those to do more than 200 cycles, 200 embryo transfers a year. The pregnancy rate standardised at that particular time. It's only if you're not doing that particular amount that your success rates will vary from month to month. I know that if some of you have got units that are much smaller, it can't be helped. But fortunately for us, when we're doing 2,500 embryo transfers a year, we have 5 nurses doing the embryo transfers. And if they can't do it, there's no point calling a doctor, because if a nurse who's doing 200, 300, 400 cycles a year, if she can't do it, you can bet your bottom dollar the consultant can't do it either. And referring back to the NICE guidelines, women undergoing IVF treatment should be offered ultrasound guided embryo transfer because this improves pregnancy rates. That's evidence-based data and published in the NICE guidelines from September of last year. Probably the greatest thing that's happened in my career, though, or certainly over the past 10 years, we now can boast in the UK, or should be able to boast, an OHSS-free clinic. Ovarian hyperstimulation syndrome, the one thing that we try and avoid, is now hopefully a thing of the past, because we can predict susceptible cases. We use softer stimulation. That's not mild stimulation or moderate stimulation or ICOS or PCOS or ALDI or Netto or whatever. It's just the stimulation as per our AMH levels. We use antagonist protocols. We're not afraid of using agonist triggers to reduce the risk and then freeze the embryo. And we adopt a freeze-all policy because we're confident in the vitrification. And our OHSS now is virtually 0. Similarly, our multiple pregnancy rates are now down to 5%. By 2012, the HFEA, the Human Fertilization and Embryology Authority, dictated that units should have a multiple pregnancy rate of less than 10%. Well, we're now down to 5% now, which we're very proud of. It could go lower, but we're really working at it. So in conclusion, ladies and gentlemen, these are the things, the marginal gains that I think are readily adapted to any unit, just to make those 1 or 2% improvements, and together they become a 10% improvement. Ovarian stimulation, use antagonists. Urinaries are just as good as recombinants, if not better. They may be cheaper. Oocyte retrieval, single channel, nice thin needle, no need to flush. Correct suction pressure, embryology, use time lapse. Embryo biopsy I'm not going to go into yet. I'm not sure whether that's good or bad, but colleagues will tell you in the plenary sessions in this meeting. Fresh versus frozen, single embryo transfer, and number 4, ultrasound guided embryo transfer on every occasion. Thank you very much. And what's the song, which you've all been waiting for? No? It's actually from the Rubber Soul album. I think it's the 5th track. It's called In My Life. So go home and play it, because the music's brilliant, but the lyrics are fantastic. So go home, listen to it, have a few beers, and then go enjoy yourself. So thank you very much.